Hey everyone, welcome to our Facebook Live. We're so glad that you're joining us today. We're trying something a little bit different today, so bear with us. We are going to be talking about the basics of IVF, but we're going to do something a little different in that we're going to kind of talk through it from a doctor's perspective and then also a nursing perspective, which is really important and really critical. You'll see kind of when we talk through this how important the nurses are in this process. And you know, this is Heather, one of my nurses, one of our very experienced IVF nurses, who's going to give us a lot of insight into kind of the patient perspective and all the stuff that they talk about during an IVF cycle. So starting off with IVF in general, IVF tend to be thought of as kind of our most advanced fertility treatment that we offer. So it's not always something that we initially start with for every patient. A lot of times we'll start with simpler things and then move on to IVF if we need to. However, there are certain diagnoses and situations where we do need to go directly to IVF. And those would be things such as if a patient doesn't have any working fallopian tubes to utilize, or we have very low sperm counts where we know that we're going to need to do IVF and put egg and sperm together in the lab. So there are certain situations where we would just go straight to IVF. So those are kind of the reasons that we would guide patients in that direction. IVF is in vitro fertilization. I would say overall it's about a 2.5-month process start to finish, the way that it's done here at Coastal Fertility. And we're going to kind of walk you through what that process looks at. And if you have any questions, please feel free to jump in and we'll have Holly pop in and let us know those questions while we're going through this. So let's start off, Heather, when you meet a couple, when they come in for their initial consult or IVF consult, what do you think some of the major fears or concerns are initially when people come in for that IVF discussion?
Yeah, sure. So obviously, you know, I don't think many people plan on ending up at a fertility center, so it can be overwhelming. They've just come and had a consult with the physician and heard a lot of information. So I usually kind of just like to do a check-in, see how they're feeling, see if they have any specific questions right off the bat. I would say oftentimes patients have questions about the medications, side effects of medications, a lot of questions about the schedule, how long it will take, flexibility with work, things of that nature. And you know, our job as the nurse coordinator is really to break that process up into kind of bite-sized pieces for them to hopefully make it a little bit less overwhelming. And we do our best to provide them with a lot of resources, calendars, checklists, videos, demonstrations. We will take as much time as we need with them, teaching them, you know, everything that they need to know and do, so that they feel, you know, well prepared moving into it.
Yeah, and I think that's a good point. I didn't mention every fertility center is a little bit different in this, but how we have our model set up here is that when you are a patient undergoing really any treatment, and IVF is included in that, you will be assigned one nurse coordinator. And so for patients that see Heather, Heather is their nurse coordinator. And just like she mentioned, really her job is to guide the patient and the couple through that process. And we'll kind of go through what that entails, but that's going to be all of any questions, medication teaching, calendar making, counseling. And I would say it's probably not uncommon that you talk to patients daily when they're in IVF cycles or every other day.
I would say
so.
Yeah.
You have a very, very close relationship with your nurse. Probably talk to them a lot more than you even talk to your physician. So let's kind of go through the cycle in general. So when we're starting IVF, there's different protocols that we use. And again, at Coastal, we don't have a standard protocol. We really do try and look at the patient, and that takes into account their age, their fertility diagnosis, all of their blood testing, how many eggs are we working with, and we really give them an individualized protocol that we think is going to help them do the best and stimulate the best. And so there's different ways to start protocols, but there usually is going to be some sort of preparation of the ovaries. And that may be a 2 to 3 week process and can include something like birth control or potentially some estrogen pills or testosterone. There's a lot of different ways to kind of prepare the ovaries, but again, that's usually somewhere between 2 to 3 weeks of preparation. Then you move into the part which I think probably is the most scary for patients, and Heather can give us kind of some more insight into that. But those are the fertility medicines that you do. And if you've had any friends or family go through IVF, these are the injection medicines that you give yourself on a daily basis. And those are the medicines that we're going to use to essentially grow the eggs in the ovaries. And so we need to get them at a size that we can get out of the ovary and use. And so you are doing medications for about 10 to 12 days. So can you kind of walk us through what those medications are, and how are they given, and is it difficult, and do patients have a lot of discomfort with that, and kind of how you walk them through the teaching of that process?
Yeah, absolutely. So typically, on average, patients are doing one injection in the morning, and they start out with one injection in the morning, a second injection in the evening, and then about halfway through the cycle, they add on a third injection that's also given in the evening. I like to tell patients that these medications are hormones that the body makes and recognizes on its own. So the body responds to these medications very well. I think a lot of patients do have concerns about side effects of these medications, but again, I usually tell them that most patients really do tolerate them well, don't really have any issues. If any issues at all, I would say sometimes like period-like symptoms, like some bloating, some cramping, things like that as we get further along in the stimulation as those ovaries are working harder. But in general, I have yet to have any patients complain of any serious side effects from these medications. And they're all given subcutaneously. So we usually recommend using the abdominal area. It's kind of the easiest to get to, kind of closest to the ovaries. And it's just a teeny tiny needle that they'll insert into that outer layer of tissue. And again, like you mentioned, we provide all of that medication teaching. When the patient comes in for their stim start, we work with them one-on-one. We allow them to practice with our medicines here in the office, so that they get their hands on things and feel comfortable with it. We also have videos that we send them. And all the medications come from a specialized fertility pharmacy. So those medications, us as the nurse will send the order to a specialized fertility pharmacy. There are several, across the country. We try and figure out who's going to work best with the patient's insurance, if they're choosing to use insurance or if they're paying cash. So there's a lot of involvement that the nurse provides in terms of the medications, and then the patient just places the order with the pharmacy, and they mail them directly to their house. But again, before the patient has to start these medications or anything like that, we sit down and we go over everything with them very clearly in detail.
Yeah, I think that's all true. I think patients do have very significant concerns about the side effects, and I agree with Heather that most patients feel pretty good on these IVF medications. There's not a lot of side effects that they feel. We have patients that come in that have had really bad side effects on birth control pills or Clomid, and we just don't see that as much with these IVF fertility medications.
Yeah, if anything, I actually have found that patients feel better.
Yeah,
because
I agree.
Their estrogen levels usually higher, and estrogen, as we know, is the happy hormone. So
kind of get you a little euphoric feeling.
Yeah.
I agree with that. And the needles, again, as Heather mentioned, they're very small, and so I think that's another concern. Just having to give yourself an injection is scary. But when I think most patients actually see the medications and the needles, and they sit down with their nurse and have a chance to practice a few times, most patients say that that's a piece of cake, and they don't know why they were so worried about that from the beginning. So that's a very common fear and concern. So once they are on their medications, I usually will tell patients that that's the most logistically challenging part. And so as far as like the intensity of the treatment from a visit standpoint, when you're on your stimulation medications, you're usually being seen in the office every few days for both an ultrasound and blood work monitoring. That's how we keep a very close track on your ovaries and egg growth. So that's the part I think that you mentioned earlier can be concerning for people that are working and have jobs and have to get into work at a certain time. And we can be fairly flexible with that. There's some points in the IVF cycle where we just can't because the ovaries are just ready and we need you to come in. But we start those ultrasounds very early. It's a very quick visit most of the time. And so patients can usually get in and get out, and then we will call them later with their instructions. I don't know if there's anything else to say about that. But,
yeah, no, I mean, definitely like the time commitment can be overwhelming as well. But I think really aside from the initial IVF stem start appointment and the egg retrieval itself, that procedure, those monitoring appointments are very quick in nature. And we absolutely can work around work schedules and things of that nature to, accommodate you.
So once we get through all of that and you're on your medicines and you're getting monitored and we have the eggs that are a size that we know is ready to come out, that's when you'll come in for the main procedure part of IVF, and that's called the egg retrieval, which is kind of what it sounds like. We're going to retrieve the eggs from the ovaries. That is done in our office here, and it involves putting an ultrasound in vaginally. It has a little needle on the end of it that we use to actually place into the ovary to get the eggs out. And so because of that, there's a little bit of a kind of a sedation anesthesia that we give. So patients are very comfortable. You're sleeping. You're not going to feel that. The procedure takes about 15 minutes. You'll hang out in our recovery room for about 20 minutes until you're feeling good, and then kind of go home and veg out the next day. And I usually tell patients, and Heather, you can tell me what you kind of find, but I think probably about 50% or more of our patients probably go back to work and normal activities the following day.
Yeah, I would agree with that. I would say, depending on obviously their response to the stimulation, how many eggs are retrieved. But I think most patients are surprised to see how well they feel afterwards, and how quickly their recovery really is.
Right. So you may be, I mean, it's not that you're going to be completely normal. You'll probably be a little bit bloated and swollen the next couple of days, but not enough that usually people need to stay home. So Heather's right. It just depends on how well you stimulate and how many eggs we get and how big your ovaries are, but fairly minimal downtime for that. Once we get the eggs out, if we are going to be making embryos, we will either get a sample of sperm from the partner that day, or if we're utilizing donor sperm, we'll have the donor sperm that day. And the lab will actually inseminate the eggs that same day as the egg retrieval. And generally that's done with a process called ICSI, or also you'll see that as ICSI, that's called intracytoplasmic sperm injection, which is a very fancy way to say that our embryology team is going to take one sperm and they're just going to physically inject it under the microscope into each egg. And so that's how we fertilize them. And then as a patient, you would be called the very next day with your fertilization number to let you know how many fertilize. And overall, kind of on average, we would normally expect about a 70% fertilization rate of all of the eggs that we get. I see.
Do you have a couple?
Yeah, I was like, I see questions popping up there. We'll take a few questions.
The first one is, will you take all my eggs at the egg retrieval? Will I have any left?
That's a great question that we get all the time. So I'll answer that one. So this kind of boils back to human biology and ovarian physiology. And so we are born with whatever eggs we're ever going to have, and that's the eggs we have for our lifetime. But each month we kind of have a group of those eggs that gets brought up to kind of be in the mix that month. And so when we're not doing IVF, usually from that group we'll ovulate one egg and the rest of those eggs die off, and we get a new group that comes up from the underlying eggs every month. And so with IVF, the medications will act to grow any of those eggs that are brought up that month. So it's just going to work on the eggs that are there that month. Again, those eggs normally die off. So we like to refer to it as we're rescuing them from death when we do IVF, because they would die if we don't use them. And then every month you're going to get a new group of eggs.
Okay, and then we had someone ask if we speak Spanish, how we handle that.
So that's a really good question. I personally have minimal Spanish skills from my time in Los Angeles. We do have a physician that is much more fluent in Spanish if you want to schedule with that particular physician. Otherwise, what we recommend is that you just bring a translator in when you come in for your visits, and that usually works fairly well.
That's it.
We good to go? Okay. So I think we stopped off at the fertilization part. So once we get the eggs and sperm together, we're going to see how many fertilize, and those are now called embryos. And then at that point, there's different ways we can proceed. And again, this is going to all be tailored to the patient, but sometimes the embryos will be frozen right away. Sometimes we'll grow those out, which is called culturing the embryos out in the lab. And that can be done up to about 5 days of growth to what's called a blastocyst embryo. And we can actually freeze the embryos at that stage. So that again is going to be dependent on the patient. But the process of growth in the laboratory is really to give us a sense of what are these embryos going to do for us? If we have 10 starting embryos, we need to have some way to tell who our strongest embryos are. And so we can kind of watch them in the lab to tell who's growing well, who's making it out to that day 5 blastocyst, who is not. There's going to be a lot that poop out and kind of die off in the lab. And I think that's sometimes a little bit of a hard concept to get when you don't do that a lot. I don't know if you have any insight into that patients' questions or concerns during that embryo growth process.
Yeah, so I think our lab does a really excellent job of informing the patient and setting clear expectations of communication, how frequently they can be expecting to hear from the lab with those updates. But yes, like you mentioned, there is attrition at every phase of the process. So we know that, however, if we start with 10 eggs, we're not necessarily assuming that all of those eggs are going to be mature. Not all of those eggs are necessarily going to fertilize. And then, like you said, just based on overall, physiology and biology, not all of those embryos are going to make it to that stage. And that can be difficult for patients to, kind of understand that concept. But typically, I think we do a good job of, setting those expectations at the beginning of the cycle.
And then that brings us to the other, question we get a lot is, do we test the embryos? And so we do have the ability to genetically test embryos. That generally is going to be done when they reach that day 5 or day 6 state, which is called a blastocyst embryo. And the way that we can genetically test them is we actually have to take a small biopsy of the embryo, which is not a completely benign process. We're actually removing, between 3 and 5 cells from the embryo to send off for genetic testing. And I think this is another, very common misconception where patients think, okay, well, I'm going to test my embryos and that's going to ensure that I'm going to have a healthy baby with no, congenital anomalies or heart defects or this and that. But that's not actually what the testing is for. The testing is what we call a chromosome assessment, which is just looking to see, does each of these embryos have a proper number of chromosomes, or is it an improper number of chromosomes, meaning it's missing chromosomes or has extra chromosomes, and the vast majority of those embryos with abnormal chromosome numbers are not going to result in a pregnancy. So I think that's a good question for you, Heather. What kind of questions or comments or misconceptions do you get on genetic testing of embryos from patients?
So yeah, I would say, oftentimes, people ask, is it possible that my baby is still going to be, autistic? Which we know autism is a behavioral disorder. So like you said, there are certain things that we cannot test for.
Right.
Unless it specifically affects the chromosomes, we're unable to guarantee that it's necessarily going to be a healthy baby that's born. Obviously our odds, increase, if we know that we are transferring an embryo that's chromosomally normal. We have hopefully higher success than just transferring an embryo that hasn't been tested, because we know from a DNA chromosomal standpoint that, it has the correct number. But again, there's unfortunately no way to specifically guarantee that it's going to be a healthy child.
Right. And I think that genetic testing of embryos has become very popular, but I think it's important for that really to be a personalized discussion between the patient and the doctor and the nursing team, because we do know that, as I mentioned, it's a biopsy of the embryo. So it's not a completely benign process, and there can be risk to the embryo, and there can be a slight decrease in pregnancy rates if we are doing the biopsy in certain situations. And so it's a good discussion to have with the patient. And this really boils down to how many embryos are we going to be working with? What is your age? Do we expect you to have a lot of abnormal embryos where we're going to get a big benefit from testing? Or are you young and we expect most of these to be normal, and maybe we're not getting a big benefit from testing, but we're maybe causing a little bit of a harm? So these are very personalized decisions where it's not an end-all be-all fix for everything. We get it all the time where, patients will say, oh, well, my best friend or my sister or my so-and-so did genetic testing, and that's great, and that may have been the right treatment for that person, but we really do try and tailor the process to the patient and give them the treatment that we think is going to give them their highest success rate. So it's a pretty thorough discussion that we'll have with you. And again, our nurses, as you can tell, are very, very experienced, very well versed in all of this. And so it's something that patients usually will run by their doctor, their nurse. Sometimes we even bring the embryology lab in to weigh in, so we can really give patients their best chance of success. So that's the main first part of the IVF cycle. As I mentioned, the embryos are going to be frozen, usually at some stage. And then most of the time, and this is not all the time, but most of the time we're doing something called a frozen embryo transfer process, which means that we are not putting the embryos in immediately. They're going to be frozen, and then we're going to come back in that next cycle to get the uterus ready and put the embryo back in. And that's really been something that's kind of taken over, as far as how most protocols are done, really in most centers, probably for the past 10 years. It just gives a lot higher pregnancy rates for most patients. And so that's kind of our standard protocol. And that's why when we talk about IVF timing, we say from start to finish, meaning from whatever preparation you're doing to the embryo going back in the uterus, it ends up being about 2.5 months. 2.5 to 3, would you say? Somewhere around there.
Yeah.
And so the part where we're getting your uterus ready for the transfer, that's pretty straightforward. I feel like I've been talking a lot, so I'm gonna have Heather walk you through what that frozen embryo transfer process looks like in general.
Sure, yeah. So like Dr. Cook mentioned, that process usually takes about a month and a half from the time of the egg retrieval to the time of the embryo transfer itself. So usually after the egg retrieval, we kind of have to put your body, if we're moving directly into an embryo transfer, we usually have to, again, like she mentioned, start preparing the uterus. So we kind of have to switch gears, so to speak. We've been focused on the ovaries. We then have to switch and kind of focus our attention on the uterus. So there's different medications that we will give, the patient will take to thicken the lining of their uterus, which is, the environment that the embryo would want to implant in. So they're usually taking an oral form of estrogen called estrase 3 times a day to thicken the lining. And then we bring them in usually after about 2 weeks on that medication to see if the lining has responded appropriately, and to make sure also that the patient hasn't ovulated. And if they haven't, then we have them start a medication called progesterone, which again, these are hormones that the body would be making on its own, and if the pregnancy were naturally occurring. And that's kind of once we start that progesterone, that's kind of when we are setting the clock for transfer, so to speak, because there is a specific window of time that we have to do that transfer in once the patient starts the progesterone. So that progesterone can either be given vaginally, but most often it's given in the form of an intramuscular injection, kind of in the gluteal area. Again, we teach you how to do those injections. And most patients, they can be tricky starting out, getting the hang of it like anything new. But the goal, again, is the pregnancy, and I think most patients tolerate them fairly well.
I would agree with that. And we're, if we're having issues, it's not uncommon that patients will come in and have their nurse look at their rear end and say, does this look right? Does this not look right? Should I be concerned? Do we need to change medications? And so we're always happy to do that. We're always happy to have you come in and help you with your injections. So we will get you through that process.
Absolutely.
So Heather's right on all of that as far as the preparation part. The nice thing about the frozen embryo transfer part, which is a little different from growing the eggs and making the eggs, it's a little bit more certain. So we can set your transfer date in advance, so you'll kind of know when that's occurring rather than having to come in all those monitoring visits and having it be a little bit more last minute. And the transfer itself is my absolute favorite part of this whole process. It's so fun. The patient is not under anesthesia, which is great because we can actually communicate. Partner is allowed in the room. It's really awesome to be able to see your embryo. You'll see it under the microscope before your transfer, which is very cool. And then you'll actually get to see it getting dropped right into the middle of the uterus as well, which is really fun. And so that's definitely my favorite part. And then pregnancy test is going to be about 9 to 10 days later. So I think that's a pretty good synopsis, start to finish, of an IVF cycle. Do we have any more questions?
We do.
Okay.
I have a couple. One of them is, when do you have to decide if you want to get the embryo genetically tested?
So it's a company that we have to set you up with in advance of the genetic testing. So ideally that is something we like to have plan in place before we start into the IVF cycle. Now, can we change our minds last minute? We can. That's not ideal, but if for some reason we do a lot better than we thought we were going to do and we do decide last minute we want to do genetic testing, we can make that happen. On the flip side, if we're planning on genetic testing from the beginning and we don't do as well and we don't have as many and we decide, okay, we don't want to test these, then we just don't test them. So we can do it last minute. Ideally, we like to have all of our plan and kind of ducks in a row before we start the cycle.
Okay, next question. Do you find someone who has multi-failed transfers should have their embryos tested?
That's a really good question. I was going to give that to Heather, but I don't think that's probably a fair question. It's a fair question. It's a very complicated question. So we call that recurrent implantation failure. So when we're having someone who's gone through IVF, who I'm assuming otherwise has nice looking embryos, and we're having them just fail to cause a pregnancy. It's a hard diagnosis. There's not a lot of great guidelines on that. So we do have some testing that we'll do for the woman on her body to see if there is a reason that the embryos aren't sticking. Maybe that's something structurally with the uterus or something, in the bloodstream, antibodies, different things we can test for. But we do often go to that. If we can't find anything else and we don't have any other reasons, we sometimes will recommend, genetically testing the remainder of the embryos. And again, that's going to be dependent on the situation.
Okay. My insurance does cover a percentage of IVF. However, the fertility clinics are not close by. Do you partner with other facilities such as Kind Body?
So we do not, we don't partner with Kind Body. Kind Body is kind of their own clinic and practice. We have a lot of locations around the South Carolina, Georgia area. And so if you're near any of those locations, any of your IVF monitoring, ultrasounds, blood work can be done at any of those facilities. We're also starting to work with a program that's kind of an artificial intelligence program where if your personal OBGYN is interested, they can actually monitor you. We can set you up to get monitored and do a lot of the visits locally and then come here for your procedure. So we do have options available to patients who want to come here for IVF but aren't necessarily local.
Okay. And I think that's it.
Okay. I don't think I have anything else necessarily. Do you have anything else, Heather, that you want to add that we didn't get out there?
I don't think so. I just, I want patients to know that when they come in, they're going to have our support from day one. And I think what you mentioned about having just a specific nurse that you can, have through you or have with you throughout your journey is really important. But we're here for you along the way. We want the best for you. So, any questions, concerns, we're here to help.
Yes, I agree with all of that. We love our patients. For anyone who's done IVF who's watching, you know that you get very close and form a very close relationship with your fertility team, specifically your nurse and physician. And we get very excited when we have our patients come visit with their babies. It just makes our day. I mean, truly, you become a part of the Coastal Fertility family when you go through this process. And Heather's 100% right, from the girls who check you in to the girls who are drawing your blood and doing your ultrasounds and your nurse. Everybody is on your team at cheering for you. And we all get extraordinarily ecstatic when we have a positive pregnancy test and we get to call you and tell you you're pregnant.
Yeah.
So if you have any other questions or just want to get a consult evaluation, please reach out to us. We're happy to meet with you at any time and just kind of review your history and give our recommendations. And I think we'll end it with that. So have a great day, everybody.